Hamid will be presenting her first clinical case presentation entitled Cutaneous Larva Migrans, Creeping Eruption. I am Dr. K. Alvia. I will be your moderator for this activity. Before we begin, may I remind everyone to mindfully mute their microphones. Questions will be entertained after the presentation. Let me now give the floor to Dr. Hamid. Dr. Alen.
Good morning to each and everyone. This is Dr. Shermalyn Hamid, your first-year resident of Family Medicine Department Traditional Program. And today I will share my clinical case presentation about cutaneous larva migrans with the title of Creeping Eruption. I also want to acknowledge my consultants, Dr. Jeanette Abutazil and Dr. Rizalyn Yusuf. For my general objective is to present a clinical case of cutaneous larva migrans, and my specific objectives are to discuss the history and physical examination of a patient presenting with cutaneous larva migrans, discuss the diagnostic procedures used, discuss the pharmacologic and non-pharmacologic management. For the general data of the patient, she's a 19 years old female, single, a nursing student from Honolulu, currently lives in Santa Maria and a Muslim. Holds for a chief complaint of pruritic rash on the right tarsal foot. When asked what she thinks about her lesion, she said, "Akala ko, Dok, kagat lang siya ng lamok. Pero nababahala po ako kasi habang kinakamot ko siya, mas lalo po humahaba yung pamumula niya." After visiting a local beach in Honolulu 1 month and 2 weeks prior to consult, patient noted a pimple-like lesion over the right tarsal foot associated with pruritus that causes sleep disturbance. There is no associated pain, fever, myalgia, weight loss, skin discoloration, muscle weakness, no history of recent use of any new cosmetics. Consultation done, no medication taken. 1 month and 1 week prior to consult, this lesion progresses in size, now 4 cm, and appear to be a creeping-like lesion. Still with the persistence of pruritus and causing sleep disturbance, still no other associated symptoms. No consultation done, no medication taken. And 1 week prior to consult, there is a progression of lesion around 7 cm. Distal lesion is now brown and flat. There's still pruritus and sleep disturbance and no associated symptoms. Patient sought teleconsultation wherein mometasone cream was given to be applied once daily, which provided some relief of itchiness. Persistence of symptoms and increasing size of lesion prompted the patient to seek consult. For the past medical history, patient has no known history of allergy to food and drug, no history of bronchial asthma and other atopy, no other comorbidities, no history of hospitalization. This is a 3-generational genogram of the family Lakibol and Gonzalez taken last March 2021. Our index patient is the 4th child and lives with her older sister in Santa Maria, Zamboanga City, as they are currently studying here. Though enrolled in a distant learning program, the problem in the internet connectivity in Honolulu prompted them to transfer here in Zamboanga. Their family is a nuclear type, and she is currently in the stage of unattached young adult. Both sides of the family reveal history of myocardial infarction, hypertension, and diabetes. Bladder cancer and Parkinson's disease are seen in some of her family members in the maternal side. There are no other family members with the same lesion other than our patient. The decision maker is her father and belong in a middle-class economic group. The obstetric and gynecologic history is unremarkable. Patient is single, a first-year nursing student who enjoys going to the beach and outdoors, especially when she is back home, and denies any vices. The review of system is unremarkable. During our teleconsultation, patient is comfortable and feels well. Due to the limitation of this teleconsultation, vital signs was not taken, but patient was asked for the presence of fever and tachypnea. For the focused physical examination, upon inspection, in her right dorsal foot to her distal anterior leg is an erythematous serpiginous with an estimated length of 10 cm. There is a papule at the proximal end surrounded by a erythematous border. There is no swelling, no discharge, scaling, and fissure. Hyperpigmentation noted at the distal end. During the patient-guided palpation, accordingly, it is not non-tender, not warm to touch, and raised lesion with soft to hard consistency. For salient features, patient lives in a tropical country with history of swimming in the beach. There is an erythematous raised serpiginous lesion on the right dorsal foot, no scaling, no edema. The lesion is migratory. It increases in length per day. There is an associated symptoms of pruritus, no associated pain, fever, myalgia, weight loss, and muscle weakness. Hence, I came up with a working diagnosis of cutaneous larva migrans. It is important to know the basics of dermatology. We should be able to identify and differentiate primary and secondary lesion. History and physical findings describing the lesion will really aid us for coming up with a diagnosis. So for primary lesion, this is the original lesion. Identification of this lesion is important aspect of physical examination. Examples are papules, macules, nodules, tumors, wheals, vesicles, bullae, and pustules. For the secondary lesion, this is the full progression or the modified lesion by regression, trauma, or other extraneous factors. Examples are scales, crust, erosions, ulcers, fissures, and scars. This is an algorithm for evaluating skin lesions found in Fitzpatrick's dermatology book that we can use as a guide when we are presented with a lesion. To identify lesion, we should determine if it's solitary, multiple, or multiple. And if it's multiple, we should check if it's a localized or a generalized kind of lesion. Found here are the example conditions. Aside from knowing primary and secondary form of lesion, let's also review the diagnostic details. Distribution of lesion may be numerous and in arrangement. They may appear over the entire body, dermatomal, in groups, in rings, crescents, and in unusual linear pattern. They may appear fully evolved, disappear completely in various stages, and may leave a residual dyspigmentation, and they can also progress in number, size, and length. For the configuration, it may appear in linear, wherein it take on a shape of a straight line, annular, wherein it annular lesions are rings with central clearing, while serpiginous lesion have linear, branch, and curving elements, while herpetiform describes group of papules or vesicles arranged like those of the herpes simplex infection. For colors, patches lighter than the normal skin is called hypopigmentation, and its opposite is hyperpigmentation. Consistency is also an essential part of the physical examination. Does it blanch with pressure? Is it fluctuant? Certain conditions may be associated with increased and decreased sensation. So for my first differential diagnosis, which is the cutaneous larva migrans, I ruled it in because it is common in tropical countries and patient has history of swimming in the beach. She presents with a migratory pruritic erythematous raised serpiginous lesion on the right dorsal foot, hence cannot be totally ruled out. So this is an example of a cutaneous larva migrans. For allergic contact, my next differential is allergic contact dermatitis. The rash develops only on the areas contacted by the substance. Changes often occur in pattern, distribution, or combination that suggests a specific exposure. I rule it in because the patient present a pruritic erythematous serpiginous rash. So if ever may na-apply yung patient in that pattern, it may present that way. So this is an example of a allergic contact dermatitis. I ruled it out because my patient present a migratory lesion. There is no burning pain, though in ACD it is predominantly pruritic than burning, and she denied recent use of any new cosmetics and medications applied on that area. So my next differential is tinea pedis. I wrote it in because because of the presentation of pruritic erythematous serpiginous lesion in the right dorsal foot. I ruled it out because the lesion is migratory. There is no fissuring and scaling. There is no central clearing. Tinea pedis is usually found interdigital. There's no hyperkeratosis. And the dorsal surface of the foot is usually clear in tinea pedis. So this is an example of a picture of a patient with pinya pedis. My next diagnosis is jellyfish sting. I ruled it in because the patient present with this lesion, the pruritic erythematous serpiginous lesion, patient went to the beach. I ruled it out because the lesion is migratory, there is no sharp stinging pain, there's no trapping pain that radiates up to the leg, and there's no swelling. Though crops of new lesions in the crops of new lesions in jellyfish appears up to 72 hours, but they don't persist as long as 10 to 14 days. So this is an example of a jellyfish sting.
Correct.
My next differential is scabies. I ruled it in because the patient present with a pruritic erythematous serpiginous lesion. I ruled it out because the lesion of the patient is migratory. It's not found in interdigital space. The pruritic is throughout the day, unlike for scabies, mostly at night siya, and tend to crescendo progressively. Bale, as days goes by, mas nag-i-increase yung pruritus. And yun nga, worse at night. And they are rarely localized. It appears to occur in cluster. So again, since our patient present with a migratory erythematous raised pruritic lesion, my final diagnosis is cutaneous larva migrans. Going to our case discussion, cutaneous larva migrans, which is also known as creeping eruption, is a clinical syndrome consisting of a erythematous migrating linear or serpiginous cutaneous tract. This most frequently occurs as a result of human infection with a larvae of the dog or cat hookworms, which are the Ancylostoma brasiliense or Ancylostoma caninum. The hookworm responsible for larva migrants are distributed worldwide and more frequent in warmer countries such as the tropical and subtropical countries. Larvae are found on sandy beaches, sandboxes, and underdwellings. For the life cycle of this hookworm, eggs are passed in the stool of the definitive host, pwedeng adult dog or cat. And then under favorable conditions with moisture, warmth, and shade, rhabditiform larva hatches in 1 to 2 days. Then after 5 to 10 days, they become filariform larvae, which are infective and can survive 3 to 4 weeks in favorable environment. Warm temperatures between 23 degrees Celsius to 30 degrees Celsius and presence of loose humid soil, shady areas, and proper aeration all favor larval growth. Upon contact with non-human animal hosts such as dog and cats, these filariform larvae penetrate the skin and carry to the blood, to the lungs. Then they penetrate the pulmonary alveoli, ascend to the bronchial tree, and can be swallowed. This larva pwede na siyang mag-reach ng small intestine and reside there and mature into adults. Then doon na magiging eggs in feces again. For humans, they may become infected when the filariform larvae in the soil partially penetrate the skin. The larvae most species cannot mature within the human since most are accidental intermediate hosts. So the larva penetrated through the follicles, fissures, or intact skin of the human using their proteases. After penetrating the stratum corneum, the migration begins. Wala dito na nagkakaroon ng tract of lesions, nagkakaroon ng tract na serpiginous tract. Then, due to the lack of collagenases necessary to break through the basement membrane, the presentation is limited to the skin. Hence, it just produces an inflammatory reaction along the cutaneous tract of their migration, which may continue for weeks. Cutaneous larva migrants occur mostly on the lower extremities. In reports of 98 travelers, lesion most often involve the lower extremities at around 73%. The buttocks, anogenital region, trunk, and upper extremities were involved in 13, 7, and 7% respectively. The lesions are approximately 3 mm wide and may be up to 15 to 20 millimeter in length. The larva itself is usually located 1 to 2 cm ahead of eruption. And its usual presentation, initially, a pruritic erythematous papule can develop at the site of each larval penetration. Many patients are unaware of the penetration site. The exposure to heavily contaminated soil may produce up to several hundred pruritic papules. Within few days thereafter, usually 2 to 6 days, it becomes intensely pruritic, elevated, serpiginous, reddish to brown tracts appear as the larvae migrate at a rate of several millimeters per day. Vesiculobulous lesions develop in about 10% of the cases, which may delay diagnosis, and lesion may become vesiculated, encrusted, and secondarily infected. The pruritus can be so intense that it can cause sleep disturbances. Eventually, the lesion resolves spontaneously even in the absence of specific therapy. This usually occurs in 2 to 8 weeks. Although longer duration of infection has been reported and cutaneous symptoms may recur days to months later. Hookworm folliculitis is an uncommon form of cutaneous larva migrans occurring in less than 5% of cases. It consists of numerous follicular, erythematous, and pruritic papules and pustules. Serpiginous tract may be absent or relatively short. The diagnosis of cutaneous larva migrans is based on clinical history and physical findings. Infected patients typically have a history of exposure to a contaminated soil or sun, and the characteristic serpiginous lesion on the skin. Eosinophilia is usually rare, so doing CBC is not recommended. There are emerging reports of dermoscopy being used to facilitate diagnosis of cutaneous larva migran. Features includes translucent brown structureless areas and red dotted vessels. So this is an example of dermoscopy. If I'm not sure if it's obvious, but there is a parang lighter color here yung sa mga arrows. Yun yung larvae. Ultrasonography may also demonstrate subepidermal and intrafollicular structures that are small, linear, hyperechoic, and hyperrefringement. So this is an example of the ultrasound. So you can find the larva in the DEJ, bala sa junction ng dermis and epidermis. And lastly, biopsy, which is the definitive diagnostic test. It is used to identify presence of tunneling larvae just above the dermoepidermal junction or in the superficial dermis. For the therapeutics, the preferred treatment is ivermectin. A single dose of 200 microgram per kilogram is given to the patient. For its mechanism of action, it activates the glutamate-gated chloride ion in the parasite, then it increases the permeability to chloride ion, then it hyperpolarizes the nerve or muscle cells of the larva, causing the death of the parasite. And it is well absorbed in a fasting state. Albendazole is an acceptable alternative treatment. It can be given 400 milligrams once daily for 3 days with fatty meal. Its mechanism of action is it converted to its active metabolite, which is the albendazole sulfoxide. This albendazole sulfoxide causes selective degeneration of the cytoplastic microtubules, hence depleting the glycogen. ATP production decreases and causing immobilization, bala nagiging paralyzed yung parasite. Then later on, causing death of the parasite. Criteria for successful therapy are relief of symptoms and cessation of tract extension, which usually occur within a week. Topical agents are also another alternative treatment option, though they can be difficult to obtain. One is the topical thiabendazole. The preparation is 50% in hygroscopic base to apply once daily for 5 days. It is effective in alleviating pruritus, and halting the progression of lesion, usually within 2 days. The next is topical albendazole. We can prepare it by crushing 3 tubs of 400 milligram albendazole in 12 gram of petroleum jelly. It has been also reported to be effective when administered 3 times daily for 10 days. Health education on how to prevent the disease is important in managing this case. So we should advise patients to wear appropriate footwear when going to a beach, advise to avoid sitting, lying, or walking barefoot on wet soil or sand, advise to cover the ground with impenetrable material for sitting or lying, avoid areas that are frequented by animals, particularly dogs and cats. As a summary, our patient presented with an erythematous migratory race serpiginous sporadic lesion on the right dorsal foot. There is no associated pain, fever, myalgia, weight loss, muscle weakness. The patient has a family history of diabetes, hypertension, and bladder cancer. With the so my analysis are the following differential diagnoses which are the cutaneous nerve migrans, allergic contact dermatitis, pinniapetis, jellyfish sting, and scabies. Patient is in the stage of major therapeutics effort. Patient is prepared and determined to follow the therapeutic plan of choice. For the plan and intervention, CEA was done to correct her misperception that this was an insect bite and to alleviate her fear. Patient was educated on the natural history of the disease and the plan of treatment. Um, Albendazole, 400 milligram, 1 tab once a day for 3 days with high-fat meal was given. I opted to give this because it is readily available in our health centers here in Zamboanga. Health education was also given on how to prevent the disease. Healthy lifestyle was promoted due to the familial history of the diabetes and hypertension. Follow-up care was done after completion of treatment. As what mentioned earlier, their family is under nuclear type of family. She is in a stage of unattached young adult. Since this is a clinical case, I opted not to present earlier their APGAR score, which is highly functional. Scream rest revealed that the family has an adequate family resources. The family is also under the major therapeutic efforts. Patient is and family is prepared and determined to follow the therapeutic plan of choice. At this part, I included explaining the natural history of disease. Ideally,
Hello.
family meeting is also important. This is the time where we can reiterate the health education on how to prevent the disease to other family member, especially on their next visit to a nearby local beaches. Um, Ideally, we should also create a family wellness plan with other family, especially for her mother and father, to prevent complications of their present illness. I was not able to collect data of their community in Holo, but if I could, I would want to know the number of cases in this area, the state of the environmental sanitation, if there are programs to maintain their beaches clean, other prevention control program, and the deworming program. For the analysis, I want to determine the prevalence rate of CLM in Holo, the adequacy of the healthcare delivery, and to determine current healthcare policies implemented by the LGU that we can use to prevent CLM. For my community intervention, still health education and community participation has a big role in preventing cutaneous larva migrants, especially on teenagers and mothers, which are high-risk population, putting up signs or posters to increase literacy rates of the community on cutaneous larva migrant. Having this lesion, it can cause a source of stigma. Patient bearing them are usually considered unhygienic. In areas with high superstition, these tracks could be associated with witchcraft, which can delay effective treatment and risk of complications such as bacterial superinfections. Putting up beach signages such as do's and don'ts like pets are not allowed, wear slippers all the time, and emphasizing use of beach mats. Enforcing health policies such as environmental sanitation through prompt disposal of animal feces, not allowing cats and dogs in beaches, and preventing access in the grounds by putting up fences. We could also work hand in hand with the local health veterinarians in deworming stray cats and dogs. So on day 3 of treatment, there is no noted itchiness. And on this first picture is the 1 week follow-up of the patient. Wala na yung erythematous and medyo nagla-lighter part yung distal part. And after 1 month of follow-up, there is a continued improvement of symptoms and gradual disappearance of lesion. Thank you for listening po. That's the end of my clinical case discussion.
Thank you, Doc Len, for that very interesting and thorough clinical case discussion on dermatology. So, Dr. Len discussed about the case of a 19-year-old male, a female with 1-month pimple-like lesion in the right dorsal foot and with sleep disturbance and increase in size and pruritus. So, she discussed about the different approaches with primary and secondary lesions and cutaneous larva migrans caused by the hookworms by cats and dogs, the pathophysiology diagnosis, and also the therapy such as yung oral therapy and topical therapies. She also discussed about the non-pharmacological management and also discussed the PFC approach for this case. So we are now ready to entertain your questions.
Yeah, okay. I would I'm impressed, no, with the way Sharmalin discussed the case because as I understand, this is a clinical case, but she even proceeded to discuss it in the PFC framework. And regarding this case, usually this is very common among children. Medyo nagtataka lang ako, teenager na ito, hindi ba?
Yes po, Doc. Bale,
Oo.
Doc, nung naligo
So,
sila ng dagat, Doc, tinanong ko, naka-slippers naman siya, Doc. Pero, Doc, most of the time daw po, wala siya sa dagat. Covered po yung dorsal part niya ng sand.
Oo. No, hindi naman, no. The lesion is not the penetration of the larvae on the skin, no, but rather it's after the larva gets into the circulation where it gets out of the way and goes to the skin. No, but the infestation is through penetration through the skin, no, by having no footwear, no, walking no footwear, and maybe and that's why it's common among children. Kasi usually very young children, they don't know that they're stepping on feces of dogs or cats, you know. But perhaps matagal na yung kanyang infestation. Ngayon lang naligaw yung larvae dun sa circulation niya at napunta sa kanyang skin. Okay, and the differential diagnosis, well, medyo like contact dermatitis, okay lang, because like in linear contact dermatitis where you get in contact with the plants, no, medyo ganun ang lesion, but regularly a contact dermatitis would be based on the area of contact with the allergen, no? Hindi siya serpiginous. Ganon din ang scabies, no? Although both are kasi they creep under the skin, di ba? Ang scabies din, the Sarcoptes scabiei, no? But the lesion again in scabies is not, is also not serpiginous, if you know what I mean, no? And it's true. That's why I was impressed, no? Kasi she proceeded to give you a lecture on how to appreciate primary and secondary lesions, no? As well as its configuration, no? Which I usually do lecture, no, as an overview for dermatology for medical students. Um, but but including the office diagnostic procedure that you might want to request. But the only problem is when you discuss about the lesion, it's better appreciated with a picture, no, than just describing the lesion. Because really, dermatology is more of appreciation of what you see, because you can really diagnose like this creeping eruption. You don't have to ask anything about the lesion. Just looking at the lesion, you will know that it's a larva migratory skin eruption, no? Because the lesion is very typical and very pathognomonic or diagnostic of the condition. One, it's serpiginous, no? Two, it's migratory. So it starts, no, as soon as the larvae will migrate, the initial lesion would heal. So parang makikita mo lang yung track ng kanyang pagmamigrate, no? And where the current larvae is, yun ang inflame, because the body, as a, you know, like any other foreign body, no, the body will mount a response, no, in the form of inflammation, kaya mapula siya and itchy. So what else? Well, with the differential diagnosis of of yung sa ano na? Yung sa yung sa what did you say about the one ano ba? Bolong? What's bolong?
Jellyfish ito, Doc?
Jellyfish, yeah. Oo, medyo kaitsura din siya, no? Kasi jellyfish medyo ganun ang itsura nila. But it's an immediate reaction, no? It's an immediate reaction. So usually, history of swimming in the water, na may mga jellyfishes, so you rule out the possibility that she might have been stung by a jellyfish, you know. But really, the way she presented the case was very comprehensive, more than what is expected. And I'd like to congratulate her for that presentation. Ano pa ba masasabi ko? Yeah, because we don't use ivermectin, no, which is a popular drug now discussed in relation to COVID, simply because the patent for human consumption, no, dalawa kasi yan. One is for the animal and the other one is the license for production of ivermectin for human consumption has expired, and it has not been renewed because simply it's used for the animals, for their infestation problem. So that's why we resort to using albendazole, 400 milligrams OD for 3 days. And alam mo, sometimes when ako personally, when even after treating, still but I haven't tried making the topical, no, preparation. what I do is actually the alternative way is mga senior moments ko. What do you call this? Joseph, nandiyan ba si Joseph? Baka you might know. Is it nitric oxide ba yun? Yung parang ini-spray mo? Parang fini-freeze mo siya? You can also use that. Joseph, andito ka ba?
Yes,
I
Doctor, I'm not sure for what,
Tama
para
ba yun?
sa CLM
Tama
po,
ba
sa
yun?
larvae migrants.
Yung, ha? Oo,
Parang-
you use that. I know surgeons use it. It's like parang nag-i-spray ka. Are you familiar with this? I don't know if the is nitric oxide. Yun ang tanda ko.
Yung silver
Like
You have
nitrate
a
po.
spray gun, no? You spray it para siyang mousse. No? Hindi
Okay.
silver nitrate. Puti siya. Yung foam ng mousse, parang ganon. Paglabas ng nitric oxide, you spray it on the lesion. So lalabas yung parang ipi-freeze niya yung at mamamatay din.
Cryotherapy ba yun, Doc?
Cryotherapy, yeah. What is the that you put? Ano yung component ng cryotherapy? Ano yung
Liquid
yung is it nitric oxide? Oo, tama. Yung procedure is cryotherapy, no?
Yes po, Doc. Nitrogen, liquid nitrogen, Doc, yung ginagamit Doc, for
Wala
carbon
akong
dioxide laser.
cryotherapy. Alam mo, ginagawa ko, sinusunog ko, kinopoperize. Although it's not the prepared procedure, no? Kasi you might cause a scar in the kasi medyo siya. Oo. Pero out of desperation, wala naman akong cryotherapy. Ganun ang ginagawa. But I'm not recommending it. But of course, if the lesion does not, or perhaps you can repeat the dose after some time. Para Okay. But really, the discussion was very comprehensive, more than what I expected. So congratulations, Shermalyn. Meron ba kayong mga tanong?
Doc Len, may question po sa chat box. So, kay Doc Adnil, yung meaning, ano daw po yung reason if why nagbibigay ng albendazole given with fatty meal?
Nag-increase yung absorption ng albendazole with fatty meal po, Doc. For absorption kasi siya, Doc, sa GI tract. So, pag nag-take with fatty meal, it increases up to 5 times po when administered with it.
Okay na po daw, Doc. Thank you. Any more questions from other consultants or from residents?
Dr. Len, just a side question, no? Hello? Can you hear me?
Yes po, Doc.
Yes, pangit kasi ang signal. I was just wondering, the CLM during its stage within the dog or the cat, na lumalaki yung yung larvae, may cycle siya within the animal, di ba?
Yes po,
Before
Doc.
it, oops, yes. This is secondary to yung mga poor hygiene din ng mga animals, correct?
Bale, Doc, yung animals, ang intindi ko, Doc, sila talaga, Doc, yung definitive host. Bale, pag ang ano din sa kanila, Doc, through skin penetration, bale, kung dinadala din po sila sa sandy areas, tapos may ibang dogs doon na naglay ng feces with an egg ng hookworm,
Yes.
Doc. So pwede din, Doc, ma-acquire nila through skin penetration.
So I
Ang difference
understand.
po, Doc, sa animals, Doc, pwede, Doc, mag-push hanggang doon sa may blood vessels nila, kaya magpunta siya sa bronchial tree, tapos pag malunok nila, Doc, yung matured larva, mapupunta sa intestines. The cycle continues, Doc.
Right, right. So I was just wondering because it's because of unsanitary conditions that the what you call this is perpetuated, the life cycle, di ba?
Yes po, Doc.
So if you have, I mean, I was thinking more of those with pets, dogs and cats. Most likely, they will not be exposed to such, mga ascals or any dog that is outside of your residence. So most likely hindi naman nagkakaroon ng ganito mga pet animals, no?
Yes po, Doc. Kasi, Doc, kailangan, Doc, yung favorable environment para, Doc, yung egg maging larvae, Doc. So kung wala naman yung, Doc, like yung moist sand, yung warm temperature. Kasi, Doc, kung like dito sa atin, Doc, kung sa may kalye lang, tapos ano lang naman, Doc, road. Diba concrete naman, Doc, yung mga ano natin. So hindi siya magiging favorable condition for the egg to hatch into a larvae, Doc.
Okay, thank you.
Actually, if you own a cat, may regular ano rin yan eh. Deworming. You bring them to the vet med for deworming.
Yes po,
Yun
Doc.
na.
Every 3 months po yung
Okay.
recommendation for deworming for the
Yeah,
dogs, sa dogs, Doc, and sa cat po.
yun nga. So, that should be safe.
Dr. Queen, kasi that's where I initially read some of the usage of ivermectin is primarily for animals like dogs, cats, and even roosters. That's why it's being
Yes.
sold in the
Uh-uh.
as anti-parasitic for the
Ibang preparation.
non-human, no?
Ibang preparation ang dosing, iba mataas yata. At yung composition din, ibang pagkaano nila.
Okay po, thank you.
Any more questions? From RPGIs, baka meron kayong question.
So, ipipresent mo ba ito sa ano mo? Sa interdepartmental?
Hello, Doc.
Pwede naman, Doc Queen.
Pag i-follow up mo talaga to, Doc Len, tapos magawa mo yung plans ng PFC, baka pwede natin to i-present. Matagal-tagal pa naman, Doc Queen, yung interdep niya.
Oo. Kasi ang point ko lang, kasi wala namang nagde-discuss usually sa Dharma. And I don't know. Or is this too common enough for you to make it as a case presentation?
Pwede naman to, Doc. I-follow through niya lang talaga yung plans na sinight niya kanina. Kung magawa yun siya, Doc, magandang case na to, Doc, for interdep. Matagal-tagal pa naman, Doc. Siguro next year pa yung interdep. So, pwedeng i-follow up. Tapos tignan din talaga yung family as well as yung community ng patient na, Doc. Para
Okay.
holistic yung pag-present natin sa interdep ni Doc Len, if ever.
Doc, naka-establish naman din po ako ng rapport sa patient. Kasi, Doc, gusto maging doktor po eh. Kaya pwede din ako makipag-usap sa kanya para makompleto ko, Doc, yung PFC, Doc.
I-enroll mo ba siya, Doc Len, sa family mo? As a sa family care program?
Pwede naman, Doc. Pero wala kasi, Doc, dito yung buong family niya, Doc. Okay lang ba yun, Dok? Na-distant na like nasa holo yung family?
Taga saan siya, Doc Len?
Taga-holo Sulu talaga sila, Dok. Kaso, Dok, nag-enroll kasi siya, Dok, sa WIMSU, Dok, ng nursing, Dok. Tapos, dahil mahirap yung signal, kaya po napapunta lang siya dito, Dok. Sakto, Dok, nung kararating niya, doon na siya nag-worry doon sa progression ng lesion niya. Kaya, Dok, napatawag siya sa teleconsult natin, Dok.
Wala siyang parang family talaga or mga relatives na sinastayan dito?
Bale, Dok, meron lang nearby relative, bale yung pang-anim na brother ng kapatid, ng mother niya po.
Oh, sige, sige. If ever man, Doc Len, kung hindi siya as family case, yung interdep naman natin, even clinical case, pwede naman tayo mag-present doon ng gano'n. Pero yun pa rin, since yun nga, yung matrix na fina-follow natin as FAMED, mas maganda pa rin talaga, we follow the PFC matrix.
Opo, Dok.
Pero pwede na to siya. Congrats, Doc Len.
Thank you po, Dok. Thank you, doctors. And Dr. Soraya for the input po.
Thank you, Doc Queen. Doc Queen, later, Doc, may EBM presentation po tayo on prognosis. Si Dr. Inkagan naman po later at 7:30 p.m. Prognosis.
Okay. Mm-mm.
Okay, sige, Doc. Thank you. Doc Kay, meron pa ba, Doc Kay?